classification and how you're going to diagnose epilepsy and how you're going to investigate epilepsy and how you're going to treat, and of course, special issues. Now, epilepsy is a common disorder, and I'm sure you remember, if you know the Mahosata, Jataka, and they're one of the aristocrat called epilepsy, but anyway, in Burma, the epilepsy rate is about 360 to 4 of the population. I can think about how many epileptic patients in our country, but it is underdiagnosed and because it is a stigma disease, people doesn't want to tell you have epilepsy, and the education and non-stigmatization to seek the treatment. Okay, and now the global prevalence of the epilepsy in the age and sex, male and female are more or less not different. You can see so sorry about that. So when you look at it, so for younger age group, it's most likely butt injury or idiopathic one, and in the early age group, because of the increased prevalence of the intracranial pathology, such as a stroke, head injury, or tumor, or etc. And when you look at this epidemiology study for admission for the neurological ward, the stroke is the commonest cause. And second is the headache, and seizure is very similar to headache. So it is a very common. If you take off the stroke, and again, headache is the commonest, and the seizure is the second commonest reason to attend hospital admission. So now we're going to talk about definition. I'm going to talk about the epileptic seizure first. Seizure is because of the abnormal electrical activities in the brain. Okay, so abnormal, excessive, or synchronized activity in the brain, and that is seizure. Anybody can get the seizure. For example, if someone hit you, like a rugby player, or you can have a seizure. For if you have an electrolyte imbalance, you can have a seizure. But what epilepsy is, if you have a risk of the recurrent seizure, you can say this is epilepsy. Let's say, for example, someone got a road traffic accident, he got a head injury, so there is a scar in his cerebral cortex. Because of the scar, there is always abnormal electrical activity, and then this patient is going to have a recurrent seizure, and we can diagnose this patient as epilepsy. One seizure you cannot diagnose as an epilepsy. Seizure is a signs or symptoms. Epilepsy is a diagnosis, similar to, for example, someone having a fever does not mean this person got a malaria or this person got a pneumonia. Now, epilepsy syndrome is normally occurred in the kids and the children. I'm sure that the commonest you would remember is absence seizure. In the old days, it was called pitamol. Okay, so people, why you need to recognize it? Because these epileptic syndrome need a different anti-epileptic medication, and also they have a different prognosis. So therefore, it is important to recognize what epileptic syndrome this patient has. Now, focal seizure. Focal seizure is a seizure originated from one place. And for example, as I mentioned before, someone got a head injury, scar, or someone got a stroke, they got a scar. So the epilepsy focal side coming from that area got focal seizure. In the old days, it was called partial seizure, but we don't use it anymore now. And generalized seizure is originate or global seizure, a patient normally associated with the loss of the consciousness. And when I was a student, we are thinking about localization related seizure, for example, temporal lobe seizure, frontal lobe seizure, occipital lobe seizures. Now, the concept of the epilepsy is changed because brain is a network disorder. So the seizure can originate from any network and distributed very quickly and can develop a generalized seizure. Generalized tonic-clonic seizure is you got the shaking all over your body. Tonic is a tensing moment and clonic is up and down shaking. It's a generalized tonic-clonic seizures. Not all generalized seizures are associated with the tonic-clonic seizure. For example, if you have an absence seizures, it is not associated with the tonic-clonic seizure. So secondary generalized seizure is we no longer use. Simple or complex partial seizures are no longer used. The reason I put it is because in the old literature and some study are still using this literature, but it's going to be gradually replaced. Now, this is a new epilepsy classification in 2017, and I will give you the two version. That one is for the first version. If you are a medical student, if you remember that, that's good enough. As I said before, focal onset seizure, it can come in from anywhere in your brain. Aware means no loss of consciousness, and impaired awareness, not necessarily you are totally unconscious. If you have an impairment of the consciousness, and motor and non-motor. Motor means you got the shaking, twitching, etc. Non-motor, for example, absent episode is the non-motor. And generalized onset, it can be the sudden onset, generalized widespread, and again, motor and non-motor. Unknown onset, sometimes we don't know. We don't know whether it is a focal onset or we don't know whether it is a general onset. Because you remember, brain is network. So onset may be the general onset or onset may be the focal onset, but spread generalized bilaterally very quickly. So you cannot decide it. Even EEG cannot decide it, then unknown onset. So if you want to know more about, so if you know this slide is good enough. So if you want to know more about it, for example, motor concept, automatism, like a banging the wall, or atonic drop on the floor, epileptic spasm, normally in the kids, and also non-motor onset, autonomic, and autonomic symptoms. and also a motor onset, clonic, tonic, myoclonic, and I will explain to you what they are for. So this is a more elaboration of the previous slide for the someone who want to know more about what are the epileptic phenomena. So these are the old classification, and just for your information, you don't need to know, but if you want to know what it is, this is what they said. So these are the signs and symptoms. That is what I'm trying to say in the previous slide. Autonomic behavior, autonomism, for example, like just banging the head, banging the wall, emotion or appearance of the emotion, crying, laughing. Extension of flexion posture is a tonic. You just tense up, flashing, sweating, eyelid erection, goosebumps is autonomic features. Jerky rhythmically is a clonus, and jerky arrhythmically is myoclonus. Sometimes epileptic patient, they stop talking, they stare at you. That is the most likely cognitive impairment. And atonic limb, patient just suddenly fall on the floor. And some people will have a vertigo, smell like a sensation, and so on. They are all self-explanatory. So when you look at it, that is applied to that phenomena, you can apply to that slide for the simple classification of the seizure. So diagnosis of the epilepsy, again, history is important, and also you need to differentiate other non-epileptic attack disorder. And there are two non-epileptic attack disorder. One is a non-epileptic attack disorder. They are psychogenic seizure. Another are not psychogenic, they are non-epileptic paroxysmal disorder. For example, if you have a arrhythmia or heart block, you collapse or faint, and that can be mistaken as a seizure. And then, of course, investigation. So in the history, what you want to do, direct eyewitness. You want to know everything from the start. You want a detailed story as if you are looking at the video kindergarten show, if you like. And you have to think about seizure markers. What are the seizure markers? Tongue biting, incontinence, trauma. And when you are saying tongue biting, and they are really, really bad bruising, tongue biting. Normally, the side of the tongue rather than the tips of the tongue. Because some pseudo seizure, they can bite their tongue very fake, but they are very minor. Incontinence is most likely seizure, but people can pee on their clothes for the non-epileptic attack seizure, or someone who has a severe fainting attack can lose the bowel control as well. Although these seizure markers are quite useful, but it is not diagnostic features. Another one I would always advise is a video recording of the attack. You have a smartphone in these days, so you record video recording, and of course, post-attack confusion. And you have to think about comorbidity, for example, any anxiety, any psychiatric symptoms, any history of the head injury, any history of the stroke, or that patient has taken electrolyte imbalance, and a history of the meningitis, encephalitis, and diabetes. They will be very helpful. Social history, and who look after the patient, because the patient is living on their own, and if the patient got a fit, it could kill the patient. Okay. Now, non-epileptic attack disorder, and I send the video attack to the moderator, and I hope he can show you and the email. And they normally long duration. Mind you, if the someone has epileptic attack more than 10 minutes without stopping it, most likely going to die. Okay, so this patient has a long duration attack, hours, 20 minutes, 30 minutes in between attack, they are okay. And all the attack fluctuate and wax and wane, and they are asynchronous movement. One arm is moving and another arm is standstill, and they are also like a shaky movement, like a no, 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 no. And they normally close their eyes. And if you try to open the eyes, they try to pause it. In the epilepsy, normally eyes are open. They show emotional lability, they might cry, and they normally have an attack when the presence of the public because they want attention. After the attack, no obvious attack confusion, and normally, seizure, you go, that sort of the breathing, they don't happen. Urinary incontinence and tongue bitings are questionable. So, and the only thing I want you to remember is a cardiogenic cause. Okay, cardiogenic cause. If you have a significant the pulmonary hypotension, and you can develop acute twitch. So for the someone young or old, and the patient developed the epileptic seizures, and do the cardiovascular examination and investigation. So investigation, what we're going to do, EEG is electroencephalography, similar to ECG. ECG is electrocardiography. And imaging, MRI, CT scan, again, cardiovascular assessment. I can't stress enough, cardiovascular assessment is important, and metabolic, of course, if you have a hypoglycemia or abnormal liver function test, and hyponatremia, they can give you the seizure, and of course, genetic. So EEG, before I'm going to go into the EEG, epilepsy is a clinical diagnosis, okay? So EEG is supportive diagnosis. Normal or abnormal EEG alone cannot confirm or exclude the epilepsy. So EEG is quite useful. For example, if you want to do epilepsy syndrome, EEG is quite useful. EEG is normally, as you remember, one seizure, you can get one seizure, but someone got the two seizure, that is epilepsy, and you want to do EEG. However, in the special circumstances, and you may want to do EEG. But if you think this is just a fainting attack, if you think this patient collapse is not epilepsy, this patient shaking is not epilepsy, don't do EEG, because 20% of the normal population got abnormal EEG. So it will confuse you, and it will make the misdiagnosis, and patient will be taking anti-epileptic medication almost lifelong by this mistake. Okay, so again, and even if you have the epilepsy, EEG sensitivity is only 65%. So 30 or 35% people will not have an abnormal EEG. So normal EEG cannot exclude epilepsy. And some people do have again abnormal EEG, never have an epileptic attack. So abnormal EEG, you cannot make a diagnosis. So that epilepsy is again a clinical diagnosis. So when you look at this is the absent seizures, and 3 spikes per wave, 3 spikes and slow waves per second, as normally a Bacon episode, normally in the kids. Another one is a JME, juvenile myoclonic seizures. They normally occurred when you started puberty, and start the acute jerk in the morning. They drop things, they drop the spoon from the breakfast, and then these patients can develop generalized epilepsy. These are the epileptic syndrome. Absent seizure and a JME can make worse by the carbamazepine. They are normally absent seizure, ethosuximide, JME, either Capra or sodium valproate. Therefore, especially in the kids, getting the epileptic syndrome diagnosis is important. Neuroimaging, and for emergency, you can do CT, and CT will probably exclude the gross abnormality. However, MRI is a treatment of the choice, because if you have a neuronal migration disorder or demyelination disorder or some metastatic carcinoma, and the MRI CT scan sometimes fail to show it. Okay, but however, of course, in the acute situation, you can use CT. Now look at the MRI scan, and you can see the big arrows in the hippocampus sclerosis. You can see the colorblind, so I don't know whether red or green. You know, the one hippocampus is small and atrophic in one picture, and another picture you can see the gray matters are in the white matter area. That is a neuronal migration disorder. Other tests, in the old days, people used to take the serum prolactin. It is useless, but you have to do blood glucose electrolytes. And always remember, someone got the epileptic attack, and especially they are diabetic or alcoholic, give the glucose plus thiamine. Okay, don't give the glucose alone. Please give glucose and thiamine, and make the bed check with the blood glucose level, and of course, and the ECG. Treatment of the epilepsy. Well, principle of the treatment, you need the correct diagnosis, because unlike other conditions, once you diagnose epilepsy, normally patients need to take anti-epileptic medication about 5 years. They are not free of side effects. So detailed history is important, and appropriate investigation is important. And the treatment is to prevent a further epileptic attack. And normally start with a small dose and gradually titrate it. Very similar to the blood pressure treatment, very similar to diabetic treatment, no difference. And of course, when you are choosing anti-epileptic medication, you have to think about epilepsy syndrome. As I told you before, someone got the JME or the absent seizure, you don't want to give carbamazepine. And also you have to think about concomitant medication because of the enzyme-inducing effect, and of some women with the reproductive age, you don't want to give sodium valproate. And also, there you have to think about drug interaction and lifestyle and so on. How to start the treatment? Start with a small dose and gradually increase. Okay, but before you start the anti-epileptic medication, it is important you have to communicate with the patient and explain an important and of the regular taking anti-epileptic medication. Explain to them, and this medication has to be taken regularly. You cannot stop it. If you stop it, if you have another epileptic seizure, depending upon the circumstances, it will endanger your life. For example, if you have an epileptic attack when you are cooking, you can think about it. When you have an epileptic attack when you are driving or when you are crossing the busy road, think about it. And in this is the anti-epileptic medication should be initiated in adults on the recommended of a specialist. And I don't think it is applicable to Burma, and because most of you will be dealing with these epileptic patients. So as far as you do careful consideration, I'm more than happy you to commence anti-epileptic medication. Not everybody can have access to that specialist, and not everybody is rich enough to be seen by a specialist. Okay, again, the same for adult medical practitioner with the training and expertise of the epilepsy. For me, as far as you know what you are doing, and you should start anti-epileptic medication. You shouldn't shy or you shouldn't concern about starting anti-epileptic medication. If you take the history carefully and take the video, the smart video of the patient having a seizure, and if you think about age, sex, and proper anti-epileptic medication, and why not? You can start. Okay, and before you're going to start, you have to explain, because the worst thing happen is you take the medication, within a week you stop it, and patient, and because epilepsy is like an asthma. Sometimes they come, sometimes they don't go, they don't come. Sometimes when they come very frequently. So they got a false sense of the security. Look, I'm not taking anti-epileptic medication. I don't have epilepsy. Why do I need to take the medication? So communication is a key. Why start the low dose and increase the medication? Because similar to the diabetic or similar to the blood pressure medication, you don't start a big dose. Okay, it's not necessary. Bigger dose can give you more side effect and more expensive. If you can control your anti-epilepsy with a small dose, you should stick on the small dose. Okay. When to start a treatment is normally not fast seizure. You don't give it to you. After the scan seizure, you want to give anti-epileptic medication. Okay, and again, I'm repeating myself as it depends on epileptic syndrome. And if it is not clear at the presentation, of course, you can wait. But there are conditions you can start with a fast seizure. For example, patient has a neurological deficit, and because the risk of the another seizure is higher, and EEG show unequivocal epileptic activity, I would start with a fast seizure, and that brain imaging show abnormal structural abnormality. Of course, the risk for the another seizure is higher, so I'm not going to wait to have a second seizure. I will start it. Well, another one is, for example, a patient who's taking blood thinner like a warfarin or anything, and if they got an epilepsy and fall over, they're going to have a brain hemorrhage. In that case, because of the risk, I would start with the fast seizure. So start with the, in theory, start with the one, like an antibiotic treatment. One is efficacious and less side effect and specific to that epileptic syndrome. Okay, so that is the main principle, and also with the more tolerable medication. And titrate anti-epileptic medication very slowly and gradually increase if required. If the first anti-epileptic medication is ineffective, you can add a second anti-epileptic medication with different mode of action, like antibiotic. You're not going to get a penicillin and erythromycin. You're probably going to get penicillin and aminoglycoside, for example. That's similar, but in anti-epileptic medication, because you cannot stop straight away, you have to overlap. What I'm saying is, for example, I'm going to give you carbamazepine, and carbamazepine in a high dose, it does not work. I'm going to add second medication like a levetiracetam. When I am adding levetiracetam, I don't stop carbamazepine straight away. I'm going to increase levetiracetam or Keppra gradually, and once levetiracetam, i.e. Keppra, reach the therapeutic level, I will be gradually weaning the carbamazepine. Okay. Now there are different epileptic medication you can start, and start with the 1960, and now we have quite a huge choice. Someone is asking, how can we know the desired dose of anti-epileptic? Again, and you have to start. That's why I told you slowly, the same like a blood pressure measurement or blood glucose level measurement. If you start the anti-epileptic medication, and if the patient has a less frequency of seizure or seizure stop, and then you don't need to increase any further. So you know this is a desired dose. The same as when you are taking the blood pressure medication, you start with the blood pressure medication, start with the low dose, take the blood pressure, and the blood pressure is keep increasing or not responding to your treatment. You gradually add another higher dose and higher dose again and titrate it. It's quite easy. It's just a common sense. Now, what sort of the seizure you're going to use? And generalized seizure, lamotrigine, levetiracetam is called Keppra, sodium valproate and sonazepam, and focus seizure, carbamazepine, and lacosamide, lamotrigine, and levetiracetam. But for me, I have to say, if you know carbamazepine, lamotrigine, levetiracetam, and sodium valproate, you do pretty well. Why? I will explain to you in the next slide. So I'm going to skip this slide because they are self-explanatory, in generalized seizure. So carbamazepine, lamotrigine, and adjunctive therapy, and carbamazepine plus lamotrigine. So that is all self-explanatory. So, but when you look at it, carbamazepine, lamotrigine, levetiracetam, and sodium valproate are in any indication. So if you know these 4 or 5 medication, you can work it out. Okay. So forget about it. Oh, there are so many medication, I don't know about it. You just need to know 4 or 5 anti-epileptic medication. In elderly population, so if you remember this slide, I'm very happy. Lamotrigine or levetiracetam, and female or reproductive age, lamotrigine, pregnancy, lamotrigine, liver failure, levetiracetam or lamotrigine, because sodium valproate can make liver failure worse. Renal failure, lamotrigine or valproic acid, sodium valproate. So you need to know, that's why liver, most of the anti-epileptic medication are metabolized in the liver, except gabapentin, pregabalin, and levetiracetam. But mind you, I never use gabapentin and pregabalin as an anti-epileptic medication because they are useless in my experience. Carbamazepine, be careful with the other enzyme inducer. Phenanthrone you can use, but phenanthrone is normally acute treatment. We don't use phenanthrone for the maintenance treatment anymore now. So you need to know some anti-epileptic medication you can give IV. Why? Someone who has a status epileptica, someone cannot swallow the food because they're unconscious, and there are IV, you can give the phenanthrone, levetiracetam, sodium valproate. So, and combination therapy, epilepsy treatment, and one medication does not work. The same as an infection, the same as a high blood pressure treatment, the same as a diabetic treatment. One medication does not work, you add another one. When you add another one, you choose the different mode of the action. And when you look at it, and the treatment, 50% of the patient will respond to your therapy. So that's again is important to explain when you are started treating the patient. Look, this medication, I will give it to you, but I have to wait a few months whether it will work or not, like a blood pressure treatment, like a diabetic control, because 50% of the people does work in the straight away, but 50% does not work straight away. So patient will still trust you. And if you fail to control the epilepsy, think about it. It may not be your fault. Of course, it can be the misdiagnosis, but it not necessarily you are wrong. It is the nature of the epilepsy. Now, especially carbamazepine and lamotrigine, especially in lamotrigine is more important. You have to do very, very slowly. And if you develop rush, you have to stop lamotrigine, stop immediately. And because patient going to develop Stevens-Johnson syndrome and it will kill the patient. Patient with the carbamazepine can get the rush. When you got the rush, stop it and give another medication. And carbamazepine can cause pancytopenia, so you need to check the full blood count every 6 months or so. If there's someone who got the infection, and think about sepsis with the carbamazepine. So regular blood tests, not always we need to regular the blood test for anti-epileptic medication, but if the patient's not, patient says, oh, I take medication, doctor, and trust me, and believe me, I never forgot, and but patient is fitting, you may want to test the blood level, and or if the patient is taking too much carbamazepine and they became ataxic, you want to look at for carbamazepine toxicity, sodium valproate toxicity. Okay. And most likely seizure is, and pregnancy is quite difficult to monitor lamotrigine level. And however, if there's an increased seizure, you may want to monitor the blood level, but I don't think it is a really applicable to Burma. Other blood tests, what you have to do is electrolytes, liver enzymes, vitamin D level. And vitamin D level blood test is very expensive. My suggestion is advise the patient to take vitamin supplement and take more sun exposure. Full blood count, as I explained to before, carbamazepine can be associated with the pancytopenia, and most of the anti-epileptic medication can be associated with the abnormal liver function. That's why you need to monitor liver function. Okay. And of course, and before patient going to do the operation, if the patient is taking sodium valproate or carbamazepine, you may want to do the clotting study because it will affect the clotting factors. Patients on anti-epileptic medication, they always have a minor abnormality. For example, mild pancytopenia, mild abnormal liver function, but we don't change the medication. A mild abnormality, you can ignore it, but of course you need to monitor it. If it's gradually getting worse, AST getting higher, ALT getting higher, and then you may want to change it. But otherwise, stable, mild abnormality, don't change. Now, breakthrough seizure. Breakthrough seizure is someone who has a pretty good control of the epilepsy. At one point, seizure come back. Okay, so most of the commonest causes are non-compliance. They are not taking medication, either because of they don't like a side effect or they do not understand importance of the taking epileptic medication, or they are expensive, they can't afford it. Or infection, any infection, chest infection, water infection, stress can increase the seizure. And the alcohol, sleep deprivation, and of course, some are non-epileptic attack disorder. Someone who has an epilepsy and non-epileptic patient, they can have a non-epileptic attack disorder. Therefore, it is important. Okay, what sort of attack? Can you record your epileptic attack with your smartphone and then check it? Women in epilepsy need a special attention for the two reasons. One is a teratogenic effect, the worst is sodium valproate, and also they can interact with the contraception. So that's all you need to know. Pregnancy, and these are the one congenital malformation. The levetiracetam is fairly safe. When you look at this, even with the anti-epileptic medication at the bottom of the graph, and 1.6%. If you give the levetiracetam only 2%, and the worst is valproic acid, okay, sodium valproate. So that's why I really give sodium valproate to the women of reproductive age. Of course, if they get older and their menopause or family planning is complete, you can't give to them. The driving is also important, and in the UK, if you have the attack, they are automatically banned for the 6 months to a year. So, and also, they were never ever able to drive the heavy vehicles like a truck. So you have to explain to the patient. And I think that is the end of my talk. I think how frequent should you monitor the blood test, and what blood tests should we need to monitor? I think I have already given in my lecture, and you not need to monitor blood level of there are two blood tests, right? One is the level of the anti-epileptic medication. We don't do normally. So only we do is if we think patient is not taking anti-epileptic medication or toxicity. Okay, and also other blood tests like a liver function test and everything, it's just only every 6 months or so. Sodium valproate and lamotrigine, and sodium valproate is more effective than lamotrigine. The question is which one is better, sodium valproate or lamotrigine? Both are quite useful for a generalized epilepsy as well as focal epilepsy. However, sodium valproate is more efficient, but more side effect, and should not give in the women. Lamotrigine is very tolerable, less side effect, and you can give to the women. So it depends upon and what sort of the patient you are having. Okay.
Okay, was it? General go, general see you. Xiao maybe would have been time we only in the she was a general pepper.
Oh, yeah, thank you.
Okay, was it? But I'm also making on the Russia is like the DeFi was it? Want to start or not? Want to start my EEG should shows an equivocal epileptic activity or no? I must say an equivocal so about
unequivocal mean Bamalu Tan they are machines.
Okay, was it? Now we going to call why recommended to start after second epileptic disorder. Let's like 35 hours.
Because and everybody can have a seizure. Just because of the one seizure does not mean this patient going to have an epilepsy, right? That was an initial the theme I explained to the student. Everybody can have a one seizure because of the electrolyte imbalance or the infection or but we don't give anti-epileptic medication just because of the one seizure. But if you have a second seizure, it's most likely this patient going to have a recurrent attack of the seizure. And that's why we diagnose as an epilepsy. It's also down to the definition. That's why we wait up to the second attack. However, even for the one attack, we give the anti-epileptic medication if, for example, EEG show epileptic form activity, MRI or CT scan show really abnormal structural changes, they're going to have a second seizure. So anti-epileptic medication is indicated for the prevention of the further seizure. First seizure, you cannot be sure, but after the second seizure, this patient is most likely to have a further seizure. That's why we have a definition. That's why we have an indication.
Okay, was it? Now we're going to call Jaro. How can we know the desired dose of AED? Was it?
This desired dose of the AED is only the titration, similar to the blood pressure medication, right? And when you give the blood pressure tablet or when you just give the insulin, you just need to titrate. So you have to start with a small dose. For example, let's say levetiracetam. Levetiracetam is normally fixed dose. Levetiracetam, we start with the 250 to 500 milligram once a day. After 2 weeks, we started another 250 milligram. So then after 2 weeks, then when you reach 500 milligram twice a day, that is a levetiracetam is quite straightforward standard dose and 1,000 milligram per day, and we stop and wait. Patient may not have another epilepsy at all. But for example, someone like a lamotrigine start with a 25 milligram once a day, and every 2 weeks, you start with the 25 milligram. For example, if I'm going to start the 1st January, lamotrigine, I start with the 25 milligram of the lamotrigine, and after 2 weeks later, I add lamotrigine 25 milligrams, so 25 milligrams twice a day, and on the end of the January, patient will be taking 25 milligram in the morning and 50 milligram in the evening, and in the middle of the February, patient will be taking 50 milligram in the morning and 50 milligram at night. So lamotrigine is normally 100 to 200, and that is a target dose. And then don't increase anymore, just wait. Unless, of course, even with the lamotrigine 200 milligram, patient is having more and more attack, I will increase it. The same for levetiracetam. So it's the principle is very similar to other medical illness like diabetes or high blood pressure. Okay.
Okay, Master. Now we're going to call why levetiracetam cannot be given in female.
Why?
Why levetiracetam cannot be given in female?
It can be levetiracetam, not sodium valproate. I don't want to give to the women because of the teratogenic effect. Levetiracetam you can give to the women. They misunderstood me.
Okay, what's it? Now, make on the co-author anti-epileptic hypersensitivity syndrome. The theoretical risks about the general. Okay.
It's rare, but there is a risk. Theoretical risk is in English, and theoretical risk means there is always risk, recognized risk, but it's rarely happen.
Now, make on the co-author why need to test vitamin D level?
Because anti-epileptic medication, especially sodium valproate, carbamazepine, and liver enzyme inducer, they make vitamin D level depletion, vitamin D deficiency. But I'm talking about in theory. But when I teach medical final part 2 medical student in Burma, I have to think about which is applicable to Burma as well. And also, they might go to the abroad to have a further study, an MRCP exam or PLEP exam. So they need to tune in as well. And I don't think I will recommend vitamin D level measurement in Burma, but in the foreign country, we have to, because they can afford it, because anti-epileptic medication, because of the enzyme-inducing effect, they are always associated with the vitamin D deficiency. Vitamin D is quite cheap. So if the patient is on anti-epileptic medication, just give them the supplement of the vitamin D in Burma.
Okay, now make on the okay,
there is one mention as if patient took anti-epileptic drug for the long time, but cannot find this drug in the market, how to safely change to another drug? Which drug is the best to change? It is a more practical level. It's all down to what is available in the market. Okay, and if you stop the anti-epileptic medication, and patient going to have a rebound and epileptic attack. So, and I have already explained to you 4 or 5 medication: lamotrigine, levetiracetam, sodium valproate, and carbamazepine. And I'm sure one of the medication will be available, and just trying to use the available medication. And there is no such a thing for which drug is the best. Of course, if it's a generalized seizure, you can use a sodium valproate, and replacement is a levetiracetam, and vice versa.
Okay, Rosa. Now, make on the cool how frequent should we need to monitor blood tests, and what blood levels should we need to monitor?
I have already I think this is a repeating of the question, and we don't need to monitor the anti-epileptic medication blood level unless it is a non-compliance and or drug toxicity, and for the anti-epileptic drug levels. But routine blood tests like a full blood counts and liver function tests and UNE for the someone taking carbamazepine or sodium valproate roughly every 6 months.
Okay, right. Now we're going to consider why an epilepsy patient cannot drive for a year.
Because the risk of another attack in the past year is higher. And even if they, for example, if someone got the epilepsy in the past January, you started treating the treatment, and if the patient hasn't got any attack up to the June, you count as a 6 month. But after the 6 months, the patient got another attack because patients for water infection, whatever reason, in the September, and then it has to be counted from the September to another year. Because that is telling me your epilepsy is not well controlled and it is dangerous.
Okay, Master. The last question, when can we stop anti-epileptic trespasser?
That is a good question. In theory, I'm going to tell you three main points. In theory, epilepsy medication can stop if you do not have any fit after 5 years. Some people say 3 years, some people say 5 years. So if you stop it, the problem is how safe it is. How successful success rate for the stopping anti-epileptic medication. If you stop anti-epileptic medication, if you have a 10 patient who hasn't got any epilepsy for 5 years, and these 10 patients, you stop it, 5 patients or 7 patients will come back with the epilepsy. So that is one point. Another point is some epileptic syndrome, like a GME, they are definitely come back. It's a lifelong condition, so we don't stop. Why only stop the drug after 5 years? Because after 5 years, and the research evidence show is that you have a pretty good control of the epilepsy after 5 years, the risk is lower, but nonetheless, the risk is there. What I would normally do is, if the patient is very good control for 5 years, before I stop, I explain to the patient, look, I'm more than happy to stop this anti-epileptic medication, but if I stop it, there is a risk, there is uncertainty. So if there's someone like who is a breadwinner and who need to earn for the family, and if you have the attack of the epilepsy and if he cannot work, he might not want to stop anti-epileptic medication unless anti-epileptic medication, he suffers side effect with the anti-epileptic medication. So you have to tell the patient. And I also do the EEG before stopping anti-epileptic medication. If the EEG stays showing significant abnormality, I normally advise not to stop anti-epileptic medication because the risk of the epilepsy coming back is higher. And again, and someone who has an abnormal MRI scan, abnormal CT scan, abnormal structural lesion, I don't advise to stop the medication. Myoclonic versus tonic-clonic versus spasm. A spasm is normally happen in the kids, and it's quite difficult to explain verbally. And myoclonic is like a very irregular, short, brief, jerky movement. One arm, that's a myoclonic. Tonic-clonic is like a shaking, like a up and down, it's a tonic-clonic. And there is a very good YouTube. So my advice would be that look at the YouTube. What is a myoclonic attack? What is a tonic-clonic attack? Tonic-clonic is and a spasm is like a just test, like a, for example, how I'm going to say spasm is, you know, for the man, if you pee, after the you pee at the end, you just twitch. That's a spasm. That's a I know the example is a growth. This is a spasm. And myoclonic is just a regular, brief, jerky movement is a myoclonic. Tonic-clonic is you just tense up and then shaking like a flexion, extension, and arm and leg movement is a tonic-clonic movement. And the best is to look at in the YouTube, because if I tell you, I doubt it, it's difficult to explain without seeing it.
Okay ပါခင်ဗျာတခြားမီးစရာမိကုန်းလေးများရှိပါသေးလားမသိ
ဘူးမရှင်းနိုင်ရှင်လည်းရတယ်ကျွန်တော်ကိုပြန်မေးနော်
Okay, yeah, machine out of my resolution of general session, you know, the long never get like by me. So general chapels and general feedback for feedback people the link a bit feedback link in my people general the recording or let people general can you share with one okay, right?
Thank you very much. And all the students, be honest. If you don't like my lecture and how I can improve, let me know. I don't want to waste your time. If I'm going to have another lecture, I want to give the lecture the way you understand. Okay, so if you do not understand or if you do not like the fact or whatever, too much information or too little information, just let me know. I don't feel offended. That has to be the two-way. Okay, and so it's not the way of the Burmese teaching, right? So you can criticize. I'm more than happy to be criticized, and I'm more than happy you to be praised